Hello, this is Dr. Lonnie Simpson, and I'm really thrilled tonight that we have a very special guest who's going to be talking to us about bone quality. And I think it's definitely something that's misunderstood. The software that Dr. Hans is going to be talking about is not used enough, and it's such an important piece of the information. And I'd like to properly introduce Dr. Hans. So hang on just for a second here while I just switch over. And then you might have to remind me, Dr. Hans, to unshare. So I'll probably remember to do that. Okay, so there is Dr. Hans, and we were recently at a conference together here in Oakland, and he gave a fantastic presentation on this topic, and I don't think you will be, I think you'll be very impressed tonight. You won't be disappointed. So Professor Hans is the head of research and development in the Bone and Joint Department at the Center of Bone Disease and University Hospital. Professor Hans has extensive experience in bone density, DEXA, okay, bone macro and micro architecture, and ultrasound imaging, which we may get him to talk about a little bit tonight too. And he's a certified clinical bone densitometrist, and he's certified as a technologist too. And I realize I'm actually going to do that too. I want to be certified in that, even though I've been doing it for years, but I think it's a good idea. And faculty for the International Society of Clinical Densitometry and bone, teaches bone density courses. So I could keep, this was just like the briefest introduction. He has authored more than 260 articles, many chapters in books. So this guy's been around bone for a little while. So welcome, Dr. Hans.
Thank you very much. Very kind introduction. So it's a pleasure to be here. So it's kind of funny for me because I'm French and Swiss, supposedly to be in Switzerland, but I have a special meeting. So I'm currently in New York. So you can see from the background some buildings, so from Midtown Manhattan. So it's a French Swiss in Manhattan. So that sounds like a movie title, but it's not. Well, so I've prepared some few slides just to put the things in the context. I won't make a long presentation, and maybe at one point we can share a video link to see the presentation from Oakland. It could be interesting if people want to have more detail. But the idea here just to scratch the surface, put that in a context, define few terms. There's a lot of confusion sometimes about when we talk about bone microstructure, bone density. People don't understand sometimes why the density and the structure doesn't go completely in parallel, what it means, and so on. And then we go, I guess, through Q&A questions. So maybe I will share my screen. Just do my presentation, just to have some slides. So tell me if you, okay, we're seeing it. Is all fine? Okay.
It's all good.
Perfect. So some of the questions we'd always ask ourselves, is your bone strong enough? Or is my bone strong enough? So pretty often say, what does it mean to have a strong bone? Let's first have an analogy with a stool. So that's something very simple. You see here, grandma just cramping on the stool just to measure the height of her husband. So whether or not it's dangerous, well, depends how solid can be the stool. So let's do through two different types of stool here. One, you have different density. One will be in wood, the other will be in metal. They have about the same structure, but just different material. And at the end, the metal one will be denser. If it's denser with the same structure, that one will be obviously more solid because it's very much similar except the density. Okay? So now, if we have something slightly different, that you have different densities, still the wood and the metal, but then you remove the structure in between the stool here, you will see that the one in metal will be in fact more weaker than the one in wood because the wood maintains the strength of the stool with this small arch between the legs of the stool to some extent. So different density, but different structure. But beside the fact the density of the wood is lower than the metal, the wood one with the structure here will be much stronger than the one in the metal. So in other words, if you want, you need to have a good density and a good structure that will make your bone happy. And that's something what you need, because if you have a good density but a bad structure, then your risk that the stool will fracture, will collapse, will be the same that if you have the opposite, a very good structure, very weak density. So you need really both to make it as strong as possible. Having said that, if I go to the osteoporosis, so osteoporosis in the early 90s been defined, even before the NIH in 2001, been saying that osteoporosis is characterized by two things: low bone mass, or low density if you prefer, and then a degradation of the bone microarchitecture. Both are leading to the fracture, okay? So you can see here a normal bone and then an osteoporotic bone. So you see the density is different and the structure is also quite significantly different. So while we know that for more than 3 decades, what's very important to realize is the gold standard right now is bone density assessed by bone mineral density and DXA technology. So it's still the gold standard, and it will remain the gold standard because it's a very good tool. That's what we have in hand, and then we're sprayed and very accurate in most of the cases, assuming we're doing a good exam, of course. But the problem is, if we're counting the number of fractures that occur in a non-osteoporotic zone, meaning osteopenia normal, we have about 30 to 50% of a major aspect fractures that are occurring while the bone is not osteoporotic.
Okay, I'd like to interject here, and I'd like to repeat that because I think that's really important. So could you repeat that again? Because I want people to understand that, because, and I'm going to say it in my own way here, that you can have normal bone density, but the bone quality may not be good, and we can still get fractures. And that's something I think, Dr. Hans, a lot of people don't understand. So
that's very important, because actually sometimes people are osteoporotic or osteopenic and they don't fracture in terms of density, but they won't fracture very easily. And some other people have a better density, but those people will fracture. In fact, it's kind of a normal in the light of the definition I gave you before, because osteoporosis and the risk of fracture is related beside many other things. But if we're just focusing on bone, it's very important that we have the density and the structure. So you may have a good density, but if you have very bad structure, your level of risk to have a fracture is still very high. So in other words, you can have the same density, but if the underlying structure within the bone is not good, then even though you have here the same density, then one will be weaker than the other one because the strength of the bone is weaker on the blue one compared to the green one.
And
so
you know, I'm just going to say this too in another way, Dr. Hans, because this is kind of hard to grasp, I think. So people can have low bone density, right? And the inside, so the inside microarchitecture is there's less of it.
Yeah.
But if the quality is good, that bone can still be stronger than somebody who has low osteopenia or low bone density, right?
Yep, true. So you need both. I mean, if you have a good density, good structure, obviously that's the strongest bone. But if you have low density and good structure, then it will be weaker. If you have a low density but a good structure, you still have the low density part, so that will be an equivalent level of risk. So if we base a decision on the sole basis of a density, then it might be completely misleading, because you may say to your patient, oh, your level of risk is not that high because your density is osteopenic, for example. Then it turned out that potentially the structure of the bone for that density, osteopenic density, is very degraded, and then the level of risk for that patient could be very high.
Okay, so we're getting some feedback from people that they're having a hard time grasping what's being said. So I think maybe I would even say talk a little slower because, and then sometimes I will interject so we can repeat some of this because some of them haven't heard it before.
Okay.
So, and maybe also they're also talking about sound, so maybe have your mic a little bit closer. Thank you.
Okay. I tried to put the microphone up there.
Ah, that's better.
Not an image, but at least it's closer to me.
Okay, very good. Thank you.
Okay, so if I repeat, what is important is that density and the structure, think about the stool I was mentioning before. You need a good density, but also that the structure is strong enough. So if you have a weak density but a good structure, you may not fracture. If you have a low density but a good structure, you may not fracture. Or you may fracture depending on the level of degradation of the density or degradation of the structure. So there is, what I mean is like one is not enough to make an unlighted decision. You need to have either both very good or both very low to be at almost no risk or at a very high risk. And everything in between can be between low density, low structure, good structure, low density, all the mix. I don't know if it makes sense. Maybe you want to rephrase in a different manner, Lani?
Yeah, well, I've been answering some questions over here. So one of the people said, so inside of bone that may have very bad density could have less chance of fracture if structure is good.
Well, you will have chance to fracture, but clearly less chance to fracture if you were having both low density and low structure. So if you have, for example, a low density but a good structure, you may still be osteoporotic according to WHO definition, okay? But within the level of risk, it could be different. Maybe let me show you a slide that will help you to better understand, okay? Let me go a bit further than I thought here. Here, you see a 3D graph, okay? On the 3D graph, you can see in one hand the BMD T-score, like according to osteoporotic, osteopenia, or normal. And then on this axis, you have a TBS tertile. The lowest tertile means a bone strongly degraded, okay? Obviously, if you have osteoporosis, according to WHO here, then that means you have a low density. So it's like a low density and very degraded structure. The bar here, the redder it is, the higher the chance of fracture, the number of fracture, and the higher it is, the higher the chance as well. So if you take the A, for example, if you have a low density osteoporotic and degraded structure, you see that your risk of fracture is extremely high. In reverse, if you have a normal density and a normal structure, your risk of fracture is extremely low, assuming you don't have other clinical risk factors independent of the density, of course, okay? If you had a fracture in the past, your residual risk is still very high, okay? But now, if you have here a patient which is osteoporotic, so low density, but the structure is good, then it will have a risk which will be similar that someone will have a slightly better density here with osteopenia, but degraded structure, which is D. So in other words, if you have osteoporotic with a good structure, your level of risk will be similar than someone which is osteopenic but degraded structure. So
Okay.
that
Yeah.
allows you to have a more gradient of risk among osteopenia and osteoporotic fracture patients.
So I'd like to just add to this to give just a real quick real life. I'm 70. I have osteoporosis. I have a -3 standard deviation. And I've not fractured. My TBS score, which is what we're talking about here, and he's going to get, Dr. Hans is going to get into how we measure that. If my TBS score is high, which correlates with the fact that I have better bone quality. And what does that mean? It means it has a little more flexibility, right? I mean, that's another good term to use.
It could be because there is some actually very strong correlation between the TBS index, which is index of structure, with the stiffness of the bone. So we have fairly strong correlation that stiffness is also some kind of inverse of elasticity. So you're right. If you have like a low density but a good structure, the elasticity somehow or the flexibility of the bone will be slightly better. It doesn't mean you're not at risk, but then it will give you a different risk profile. And then depending on that profile, I may treat my patient differently. And that's very important because depending on the profile of my patient, I may give a different type of drugs, or I may advocate some better exercise or food or some other things, depending very much about the age of the patient and the other clinical risk factors.
Yes, and I think the thing you and I have talked about, and here's where it really helps me when I'm working with patients, is when they're in that gray area. They've never had a fracture, they have a negative, like me, they have a -3. And that's where that bone density for me really becomes very, very helpful.
Well, that exactly.
I mean, the TBS.
For example, here on that slide, if you see the green, the orange, and the red, obviously, if you're osteoporotic here, according to BMD alone, well, you say, I'm osteoporotic, I'm osteopenia, I'm healthy. That's the only information you have. But we know that there is gray zone in all these parts. So now by adding TBS, if you're saying, oh, you have a good structure, partially degraded structure, or degraded structure, that will fine tune your level of risk within the BMD category.
Oh, that's so, that is like, that's, I want everybody to get that. So that right there is what people need to understand. So please say that one more time.
Yeah. So even though people are osteopenic here, the level of risk of someone osteopenic will differ according to the level of the structure. If you have a good structure, then your level of risk will be lower than if you were having a degraded structure. And you can see here with the color code here, if you have osteopenic but with degraded structure, then your level of risk will be similar than someone which is osteoporotic.
And that's huge right there. So if you look at that column, everyone, where the osteoporosis is, you add that TBS score in, and it's a good one, your risk for fracture is less. So that's really what we're talking about here, isn't it, Dr. Hans?
Yeah. The thing is the fact that, for example, by adding the structural information here, we will improve the accuracy of selecting the fracture from 54 to 70%.
That's huge. That's huge.
So that's a huge improvement in recapturing those patients that were missed potentially. And even though you're osteoporotic with good structure, you're still at risk, but then the intervention you will have to those patients will be different than if you didn't have that risk level or that information. So that's very important.
Okay, sounds good.
Does it make sense?
Yeah, making sense.
So another thing, so maybe let's go back to some slides before. So how to measure that? That's what we're saying, that there is a software. So of course, there is many technology out there that can measure the bone microstructure of the bone as a real measure, like a micro CT or extreme CT.
CT is, remember, we're talking to lay people too, so that's a CAT scan.
Like a scanner. That we call a scanner or tomography or scanner, or like a special one where they can really go deep in your bone and having a micro measure of your bone. But this is really not for clinical routine. And then the availability of these devices is not that obvious. And then you have also the radiation issues. So here we have work from the patient to that. We spent so many years trying to find a way by extracting the microstructure information by having an index from a DEXA image. So you can have exactly the same density as you can see here, two different patients, but the structure will be different if you apply this algorithm, special algorithm been used in geophysics and satellite image from NASA or space, aerospace, and so on, just been applied to the bone field. So what we can detect from that with a special software is a structural information from the 2D image and give you a very important information about the bone microstructure. Having said that, we don't need to re-irradiate the patient. It's just a software you plug on the DXA machine or the bone densitometry, and then every time you have a DEXA scan of the spine, within few seconds, you will be able to extract by post-processing, post-acquisition processing, you will be extracting that TBS analysis. And then if you have a high TBS value, that means you have a good structure. If you have a low TBS value, that will mean a worse structure.
Okay, so let me just add to that. So let's say somebody, because this happens a lot, Dr. Hans, people will say, well, I had a bone density 6 months ago. Do I have to go back in? No, you don't. If they have that, but that software. But if your doctor didn't order it, it didn't get done, and they actually have it.
Yeah, that's true. That's a good point. One of the characteristics of that software, and that's why there have been so many validations. There is more than 520 now publication in national and international journals, and also being incorporated in many guidelines. But why that? There is so many because the software can be retrospectively applied to the patient. So that means if you have even 3 years or 4 years data, the doctor can pull out your scans and recalculate the history of the structure over time, assuming, of course, that the doctor has the software or the referring doctor is asking to the radiologist to do the measurement. Because sometimes we have many doctors have been ordering the software in the United States, but nobody's asking for it, so they don't feel like doing it by themselves if the referring doctor didn't ask for it. So why that? Unfortunately, the company behind is Medimap is a small company, so it's very difficult for a small company to reach out to everybody. And there's clearly a long education to be made, and Medimap is working that, Society is working that, Lana is working on that, Lani is working on that, so many people working, but it's still very long road before reaching out all the people that really need to do it systematically, because it just takes a few seconds, and that can really be important piece of information.
Right. So those of you who are sending in notices now about not being able to get it, and someone even said that UCSF refuses to do the TBS, we'll address those questions at the end. So thank you.
Yeah, will. Okay, so when you have calculated the TBS, that's the way it looks like. It looks like very much a DXA report. So you have an image where you have the structure of the bone overlapping the DXA image. You have a reference curve where it will give you the TBS value. And if you're above a certain value, you will be considered as a good structure or partially degraded structure or degraded structure. And then you will have individual value and so on. So that's the way the current report is. And then doctors that have been trained, especially if they receive the software, they're supposed to have proper training, then they're supposed to interpret that in a proper manner. Although it's not easy, but I will show you in a while a new report that will be pushed, and the way it will be better to interpret, that will be pushed to the field in a month from now, helping doctors to better interpret the TBS result in a combination with clinical risk factors and also the BMD. Okay, so one thing is important. So the fracture prediction, I just talked about it with the slides I showed you before, so we'll skip this one. One thing which is very important for people to understand is the concept of secondary osteoporosis. The primary osteoporosis is mostly the one related to age and menopause, where we get older, then the bone will just start to lose the density and the structure will be degraded. So that's a normal process related to age. Even though it's a normal process, at one point we'll reach a level where that normal process will put us in a level of risk and then fracture. But then you have the whole field of what we call secondary osteoporosis that could be related to many other factors, either the lifestyle, that by having, for example, being drinking too much or smoking too much, but it could be related to disease that will have a negative impact on the bone. And this is just example of some of them. For example, diabetes, type 2 diabetes. For example, in type 2 diabetes, the density of the patient tend to be normal or even supranormal, while in fact, those patients are fracturing pretty often. And in fact, it's interesting because in diabetic patients, if the glycemic level is not controlled, then it seems from studies that have been made, and that it's also in a guideline, that the structure of the bone will be degraded. So you may end it up by having a strong density, but poor bone quality. That's also true with glucocorticoid therapy. And that could be different level, could be because you have asthma or because you have rheumatoid arthritis. So the treatment of cortisone is very good for many aspects. It will heal the disease, but or heal you partially at least. But at least what we have a negative effect on the cortisone on the bone, on density, but even more on the structure. It could also happen in primary hyperparathyroidism or HIV patient. The treatment will have a negative impact on the bone, renal disease, but also, for example, in patients with breast cancer with anti-aromatase. The anti-aromatase for the breast density, for the breast cancer, for example, will be good for the cancer, the disease itself, but unfortunately will damage the bone, and then will have even more impact on the structure that there is on the density itself. So that's important to understand, because that also explains sometimes why we have fairly good density or the density in a gray zone, but then suddenly a very, very low structure index like the TBS, that maybe or because there is an underlying causes behind that. And most of the time, the underlying causes could be a secondary cause, such as I say, glucocorticoid, asthma, diabetes, or pre-diabetic, and so on and so on.
Well, and I just want to underscore the fact that what I see very commonly is that people are not, a lot of doctors do not order the proper lab work. They'll have a high serum calcium or high end of normal. They're not checking for the parathyroid. I mean, this is the not ordering proper lab work and doing a full assessment, which, by the way, is in my book. I'm just letting people know, because you want to understand exactly, have you been diagnosed properly? And part of that, in my mind, is this TBS score, because that's the bone density is a big chunk to understand, but understanding the bone quality and the TBS score is just a huge piece for me as a clinician.
Yeah, there is a few things that are very important. Clearly, the density and the structure are very important, but we should not also undermine the clinical context, meaning the clinical risk factor, the environment, what's happening behind, maybe biomarkers or markers, because every different parameter will give slightly different add-in value that will just complete the whole pictures by adding pieces to the puzzle.
Yes.
For many years, it's been said that osteoporosis can be perceived as a very simple disease. They say, well, it's just related to age and, nothing we can do about it. But I see it's totally wrong. And actually, the osteoporosis can be a very complex disease, even though it sounds easy because we don't feel it till it's too late. And that's the problem. But in fact, the consequence of osteoporosis is not only fracture, but just we have to keep in mind that about 20% of people are dying from hip fracture within the year of the hip fracture. Even in vertebral fracture in elderly people, we have complication, and about 20-30 people are dying also for severe vertebral fracture in the elderlies. So it's not only that, and we're not even talking about comorbidity and the fact that your lifestyle will change dramatically and so on. So it's a bit just more than just density and a diagnostic. The consequence behind is pretty severe for many aspects. And then it's not just density, it's much more complex. Density, structure, clinical factor to understand what the underlying cause, markers just to see whether or not it's dynamic or not dynamic and so on.
Okay, so what you're referring to is bone markers, which allow us to determine whether or not active bone loss is occurring. And
Exactly.
and that's how we monitor whatever treatment program somebody's on. I do bone markers to determine where, if they're actively losing. So some people can have osteoporosis and they're not actively losing. They
Yeah.
might have developed it early on. I mean, it's so important to know.
That's very common. For example, with vertebral fracture, you may have a vertebral fracture being diagnosed by hazard. To say, oh, I didn't know. Why you get a fracture? Does it mean you just had a fracture? No, maybe that fracture occurred 10 years before. So it will not be dynamic, but the risk to have another one will still be there. So it's not because you have it now that it didn't happen in the past, and vice versa. So that's very important, just to have the context and know the whole things.
So I'm wondering, since you and I are talking, because we have these little small pictures here, if we just might want to, we're having a great dialogue here, if we might just want to go to the questions, unless there's slides that you think would be really important to add here.
Yeah, actually, yes. The next one is monitoring the treatment.
Okay.
And I know I've raised some question about treatment. I think it's important to realize that not all the treatment will have the similar effect on the structure. They're all more or less improving the density, okay? But not all of them will improve the structure of the bone. And if I just make here a summary of several studies from different molecules, where here you have a PTH, which is a very strong anabolic drug, and then anabolic will be like a Forsteo, for example, or the one from Radius Pharma, which frankly, I don't recall the name because it's not yet in Europe.
Well, Forteo is what you just said, and Timless is the other one.
Yeah,
and
exactly.
Evenity is the new kid on the block.
Yeah, the Evenity will be Rozumab from Amgen here. It will be mostly here, or maybe even potentially above that one. But what we see here, we have the Prolia here, we have biphosphonate here, we have hormone replacement therapy here. Here is the placebo, and this is a negative drug like cortisone, anti-aromatase. What you see here is the potential positive effect on the density, and here's the positive effect on the structure. So you see that depending on the molecule, you may have a strong effect on both the density and the structure, or you may have a strong effect on the density, a bit less of structure, but still, or you have here mostly like a maintenance, a positive maintenance of the structure, but a good impact on the density, while the hormonal therapy will have a good impact or mild impact on the density, but the structure loss will be slower than in a placebo group if you don't take anything. And here you can see if you have cortisone or anti-aromatase, the impact would be negative on the structure and on the density. So what I'm saying that is very important, because if you have different impact of the different molecule on the density and the structure, then if we go back to these things here, then depending where the patient will stand, in which category, then you may choose the type of treatment accordingly, and then just try to have a better selection of a better drug for a better patient, for the patient, because we have a more personalized, to some extent, patient profile, and then we'll make a better decision. So on that standpoint, the fact that all the drugs not reacting the same to density and structure, that give us a better choice of whether or not I will give a biphosphonate, for example, or denosumab. For example, if I take here an example with
denosumab, give them a name.
Denosumab, sorry, it's a Prolia.
Yeah.
So clearly, without talking, let's assuming that the clinical context is all fine, there is no intolerance whatsoever. So make it simple. For example, here, if I have to treat my patient in this zone because the structure, the density is about okay, but not too much, but the structure is very degraded, I know that if I look at that, if I give a biphosphonate, it will have a minimum impact on the structure of the bone. So I will not improve the outcome. So in that case, instead of to give, for example, Fosamax on that patient, I will give a prolia because I know that I will improve my density and the structure, the way I will put my patient at a lower risk zone. It doesn't mean we remove the total risk of the patient, because again, sometimes if you have clinical risk factor that been there, for example, a previous fracture, whatever treatment you will do, you will reduce your risk, but the residual risk of fracture still be there. So you'll be never completely outside, completely normal for internal fracture risk. Does it make sense?
Yeah.
Okay, so if I put that in different contexts, for example, for a patient, then I will few steps that I will do just to deal with the density and the structure. It's kind of a summary of what I said before. So the first thing I will do is I will check the quality of the image, because I've seen a question about whether or not the impact of the quality of the image could impact the TBS. The answer is definitely yes. The GIGO concept, which is garbage in, garbage out, that we use for BMD, DEXA, is also valid for the TBS, because the structure, if we don't do a good acquisition, if we don't position the patient correctly, if we don't position the analysis of the patient over time in a similar manner, then the impact will be also density and to some extent, more or less, on the structure as well. So I will first check for the quality of the image. Second, I will see whether my patient is normal microstructure or partially degraded, or degraded microarchitecture. And I will see at fleet here with a normal reference curve if I'm within normal compared to my age. But then after, I will look at, okay, now I take the BMD and I take the TBS and I see where I'm localized here. Am I at the highest risk? I'm at a high risk, low risk, or lowest risk? It doesn't mean no risk, but lowest risk. Then I will see where I am. And depending where I am, depending my clinical risk factors, the FRAX, or different way of doing it, then I will choose the proper treatment for my patients. Okay? Obviously, taking into account the clinical context, the potential side effect of the treatment, and obviously, if I've already a previous fracture, then sometime, whatever the BMD result, whatever the TBS result, I will give a strong antibiotic drug because I have a very severe fracture or several fracture. So that's why it's very important for the doctor to integrate all that. And you can see it's not that simple. So that's why the doctor have to be really aware of all the different factors to take into account to make the best decision for the patient. Then down the road, you will follow up your patient over time. And what you want to do is just to treat to what I will call a lower risk zone, meaning that I want to reduce the level of risk to my patient. Can I take that risk to zero? Very unlikely, because most of the patients have other clinical risk factors that sometimes, unfortunately, are irreversible. You cannot reverse it. For example, the age, you can't reverse it. We'd love to, but it's too late. So if we have a vertebral fracture, well, we can't reverse that. It's too late, you have it. So you can reduce the risk of having another fracture, so we can reduce the level of risk for the patient, but that's the target we will have, is try to treat the patient to a lower risk.
Okay, can we unshare now just so we can, I want to see the full picture of you while you're talking. Okay, so boy, I'll tell you, we could talk 3 hours here.
Yeah, and I'm talking too much, so I know.
No,
so you
no,
have to
no.
stop me for sure. I can talk hours as well.
No, this is so important. And also, I think you and I may have some differences, and that's okay. And maybe we'll get to some of that, because I'm not a fan of Prolia, and I'd love your opinion about that when we get to it. But if I can just kind of make sure that I got what you said correctly about the anabolics. Remember, anabolics are bone medicine. And remember, we're not talking about nutrition tonight. We're not talking about gastrointestinal health. We're talking about medications.
Okay.
And approaching, because I have a lot of people in this group who are very deep into what they can do about their bones, and they're, exercising and doing, they're your perfect patient.
Okay.
But
Yep.
but we're talking about medications right now. So as I understand it, Forteo, which is
Uh-huh.
the PTH one that you had in your diagram,
Uh-huh.
that is going to have the most impact on bone quality. And I remember one of the questions that somebody asked.
Osteo and team loss. Both of them
Yeah,
are very
yeah,
strong.
Forteo and Timlis. Yeah. So
Yeah.
Forteo and Timlis, by the way, are in the same category of medications.
Even
Whereas, like, yeah,
yeah, they are in the same category, but they're just acting slightly different. While the
slightly different.
not would
Just
have
like
more impact
Fosamax
for
and
both spine and hip rather than well, that's a different story.
yeah, just like Fosamax and Reclast, and they're all different, but mostly impact the spine.
Exactly.
But Forteo and Timlis then would have the most impact from your studies and all that on the bone quality. But somebody asked a question, I think it was Berta in the questions. After the first year of Forteo, do we see, or any of these medications, do we see a decrease in bone quality?
Okay, well, supposedly no. So what I'm saying is, in average, most of the patients supposed to improve the structure under anabolic drug. Okay. However, that always there is a but. There is a but somewhere, and all these drugs doesn't work in 100% of the patients. Some people are not responder for whatever reason. So sometimes they may not be even responder even in terms of density. Sometimes they will be mostly responder in density, but maybe the impact on the structure will not be as good as we would expect. And that can happen sometime. We have almost no drug that will work in 100% of the patient. If it was the case and that everything was perfect, then we will have 100% reduction of fracture, which is not the case. For major fracture, for example, for hip fracture is between 40 to 50% reduction. For vertebral fracture, it can go up to 80%, so which is pretty
Could you
good.
repeat that for the
So
vertebral?
what, yeah, for vertebral fracture, for example, with romosozumab or
Okay, again, you got to use the common names. So Avinity is a new
yeah,
drug, everybody.
Evenity or Prolia or even a team loss, then those will reduce the rate of vertebral fracture by 80% or sometimes slightly even more the first year. So a very strong impact of vertebral fracture, but maybe a bit less on the hip will be potentially 40 to 50% or globally about 50% for global.
Yeah. So what? Yeah. So the thing is, and some people are even saying they've never even heard of these, and that's because the vast majority of doctors, quite frankly, and especially here in California, I think I've shared this with you, Kaiser, which is a HMO,
Yeah.
all patients who get diagnosed with osteoporosis, none of them are really worked up other than blood chemistry and a CBC. Rarely are they giving on 24-hour urine. All of them are put
Yeah.
on Fosamax and told to come back in 5 years. So this is
Oh,
why
wow.
you all are attending this type of a webinar, because you need to understand if your doctors are handling your case properly. I know you've seen this.
Yeah, well, that the problem. For example, I will take one case. It was a patient of Professor Krieg, one of my colleagues, who unfortunately passed away. But we had a patient that was losing quite significantly bone. It was osteopenic, and he lost about 10% of bone within 2 years. And then we said, "Wow, maybe we should put that patient on biphosphonate." And then we followed the patient, and 2 years after, the patient had a vertebral fracture, beside the fact that he had like a 5-6% increase with biphosphonate, with the Fosamax at that time, during that period of time. So we retrospectively analyzed the past of that patient. And obviously the first year, the patient lost about the same amount of structure that the BMD, about 5-6%, slightly about that time. But
They lost, when you say they lost, you're talking about the bone density. You're talking about the
first, before we put on biphosphonate, the
right.
patient lose density and structure also. So when we put that patient on biphosphonate, was interesting. The density improved by 6, 7, 8%, something like that after 2 years. But during the same period of time, the patient lost about 5-6% of bone structure. That means that we were improving the density, but the degradation under biphosphonate was still occurring with that very specific patient. And then after 2 years, that patient had a vertebral fracture. So we switched that patient from biphosphonate then to Forsteo. And for that patient, then we follow that patient a year after, and then we see kind of a picked up in terms of density and structure, and the patient didn't have any other.
So when you say structure, you're talking about the TBS score, and you're talking about bone quality. Is that correct?
Correct.
Okay. And when you, and I think I got some hesitation from you before, so I want to actually get this. When I said that bone quality represents or correlates with flexibility, that didn't seem like a word to you that you would use.
Well, the thing is, bone quality is much more complex than just structure. So the bone quality is a mix of different terms. Okay, so the bone quality, generally speaking, it's a mix of density, structure, macrostructure and microstructure, degree of mineralization, and other parameters. So that means it's much more complex than just A and B. It's many underlying parameters in the bone quality, so to speak. So that's why I tend to prefer to say, well, density and bone structure, because in the quality of the bone, there is many other factors that can be there. For example, the degree of mineralization, for example, when we talk about increasing the density, you can increase the density, but have a density of a good quality or of a bad quality, depending, for example, the degree of mineralization or other parameters. So it's a bit more complex than just having one or the others.
Okay, let me ask you this here. Hang on. So this is a, this is from, I think NOF, or NIH.
Yeah.
So osteoporosis, do you agree with this statement? So osteoporosis is a skeletal disorder characterized by compromised bone strength, predisposing increased risk. Bone strength reflects the integration of two main features, bone density and bone quality. But you feel that word bone quality is...
Yeah, bone quality is more than just structure. Behind bone quality, there is, if you say, for example, bone strength, or bone strength, you say bone strength is not enough. Bone strength reflects density and quality.
Yes.
Quality has been reflected by structure at a micro level, micro level, mineralization, and other things. So there is underlying parameter that will make it bone a good quality or a bad quality. It's not just the structure. So it's many different parameters behind it.
Okay, I get it now. All right, so I do want to go back to Forteo for a moment and Timlis, because they do strongly increase osteoclast. And osteoclasts, everybody, are the type of cells that chew up bone, okay? And osteoblasts build bone. So you have both of those going on the first year. So are you saying that at the end of that year that neither of those drugs will necessarily promote, if you will, loss or show the TBS score going lower?
So again, supposedly, those two drugs, beta and duoxetine, will improve both the density and the structure.
Right.
So that will be the majority of the patient. Keep also in mind that if a patient doesn't improve very much the structure or the density over 1 year or 2 years, the fact that he's not losing bone is almost a gain by absence of loss. Okay, so maybe that patient, for whatever reason, depending the underlying conditions, if the patient have, like for example, is taking a very strong, is taking a lot of cortisone, for example, the positive effect of the Forsteo, for example, might be smoothed out by the negative effect of the cortisone. So the effect will not be as efficient that if you were not having cortisone.
Gotcha.
Okay? So if you have a clean bone, saying no side treatment whatsoever, no other underlying condition, then normally, and you have a good compliance, because a lot of the time patients tend to, especially for Forsteo, just to inject the Forsteo on a daily basis, or I'm not very serious about injecting every day. Maybe I will do that once a week or whatever, or I forgot this month because I'll be on vacation. So all the cases, and that's normal life, you know. So what's happening here is in that case, maybe the treatment will not be as efficient. Now, again, if everything is in a good condition, most of the patients should have a fairly good response to that treatment, as majority of patients are supposed to do.
Do you have any evidence? Because again, a lot of folks on this call are very much into nutrition. So let's say you've got somebody who has -3 and their TBS score, maybe we should go over what the TBS scores actually are, what degraded and all that means, but let's just say partially degraded. And if they then correct the fact that they've been eating a horrible diet, not getting enough protein, not getting enough calcium, and in my case, of course, I'm working people, it's not just about vitamin D and calcium, it's about magnesium and protein and the whole thing. But do you have any evidence that when people change diets or fix gastrointestinal problems, that the bone quality will improve or the structure will improve?
Well, to my knowledge, I haven't seen any really randomized, double-blind, placebo-controlled study, just very serious study just to do that. Now, having said that, obviously, if you want to make a good plant, you have to prepare the soil properly just to make it better, okay? And that's the same with all the food and the exercise, the lifestyle things. If you don't do things, for example, certain lifetime condition, if you don't do it right, may neutralize partly the effect of a drug or something. So the fact that you have a good lifestyle, a good food, good thing can fix already a lot of things to a certain level. It will not be the anabolic effect that one will expect, for example. But if, for example, if you have a good impact loading exercise, you have a well-balanced and good impact loading exercise, the exercise itself can improve slightly. Well, depending what you mean by slightly, or a lot, or not a lot, but that will clearly improve or at least maintain the structure of the bone if it's done properly.
And that is, I love that you said that, because I've seen it true. So let's say that somebody does not have parathyroid disease, is not leaking calcium out of their kidneys or whatever else could be going on. In other words, they're not actively losing, they're losing age-related loss, which is about 0.5 to 1% a year. I've seen that stabilize when people, just make those lifestyle changes. And if you don't lose bone, if you stabilize, that means your bones are actually working. So I think that's an important part.
Yeah, that's what I was saying before. If you don't lose bone, it's a gain by absence of loss to some extent, because in a normal condition, well, with the aging process, you're supposed to lose bone, lose density, lose a structure. So if by your lifestyle, you at least, even if you don't maintain, but you slowing down the loss, then at the end of your life or a certain period, you may stay above a certain level of risk, and you will minimize or you will decrease the likelihood of having a fracture. It doesn't mean it will decrease completely, but at least you minimize or you will pushing that level to a later age. So clearly, whatever you do, but even if you take drugs, the nutrition is a very important part of the disease.
Right, you're not going to get the impact that you want if you don't do that, right?
Mm?
You're not going to get the impact of the medication to its fullest extent if you don't do the nutrition and really.
True. That you may not see as nice impact that you should do, or maybe even the clinical trial, maybe they will have a much better outcome themselves in the phase 2 and phase 3 trial if they were controlling the nutrition habit of the patient and try to have a a convergent strategy by being sure that nutrition is at good level, exercise is at good level, and then the treatment is at good level. So if you put all the green cards on the table, then it's like a poker. You had all the good cards in hand just to make the right call.
Yeah. Okay, we're going to go to the questions now that we had. Now, we have lots of questions that have come through. We're going to, and even before I do that, I want to show where people can write send an email. Shelley, what is Shelley's last name? Shelley Horn, works for Medimaps. And I want to give you the number that, or the email that you can send to. We'll do this again at the end. But you can send an email or go to this website. And if you fill this in, then you're going to fill out a questionnaire and they will contact you. If you're having trouble finding out if you have a TBS score in your area, or even the clinic that you have, they will contact them. So I'm going to give you a second to write that down. That's medimapsgroup.com/find and then a dash, a dash clinic dash with dash TBS /. So don't write me. Go there, and we're trying to really educate people to, and hopefully get more people to get this particular important piece of information. I'm going to go to the questions now. Okay. And I'm only going to select a few here because you've answered a lot of them actually. But here's the top one here. How accurate is TBS? So if I go to Hologic on one day and I go to the GE on the same day, there's going to be some difference, but overall, how accurate is it?
Well, I don't know what accurate means. Accurate for what? So that's a tricky question. If we talk about accuracy of TBS in terms of fracture prediction, then it's equally good than the BMD, that's the DEXA. So it's a pretty accurate technology. But then after, the accuracy of the measure depends on how accurate the technician will do the measurement itself. So garbage in, garbage out. But everything being done just to minimize the impact of many things. But as today, it's a fairly accurate measurement.
In other words, if it's done correctly, if
done correctly, yeah. And also accuracy is good up to a certain level of BMI. So that means if you have,
can say what that is.
Yeah, in an obese patient, for example, there is too much soft tissue above the spine just to make it very accurate measure of TBS. So in that case, I will be cautious about the result.
Okay, great.
The software will pick up that and will tell you, be careful, you're out of range to have an accurate measurement. And then the doctor should not interpret, or at least interpret that with caution.
Okay. Now let's say somebody has a bone density 2 years ago, and their TBS, and by the way, if it's a 1.4, that's really good. That means your bone density is normal. Yeah. But let's say it comes back and it's only 10% either lower or higher. What number percentage? Now this is assuming the bone density was done correctly. What percentage do you like to see that you can hang your hat on that that's something you can rely on? In other words, the TBS has improved, or it's going the other way. So what's a number that you feel comfortable with, assuming that the bone density was acquired properly and all that?
Yeah, assuming that everything applied properly, you still have what we call in a densitometry, what we call the least significant change. So that means how much change we can say for sure it's a real change and not related to the variability of the technology and the machine. Okay, so if we take in a worst case scenario 1.5 to 2% in terms of precision errors, then with a less significant change, that means up to 4% or 5%. Within that range, you have to be cautious about the change, okay, as an individual level. Now, if you're above that, you know that there's a real change.
Okay, and the same with bone density.
Exactly the same, that density. Maybe density will be 3 to 5, maybe TBS will be 3.5 to 5.5. So
yeah, so when people say, and a lot of you are in groups, oh, I've gained like 1%. or 2. That doesn't mean that that's accurate. That's within the least significant change that we do.
Well, that means it's reassuring,
Yeah.
because that means you're not losing. It's reassuring, but it's not enough. So it's not because you gain 1% that you should say, yoo-hoo, I'm okay. I don't take my drug anymore. I don't take care about the lifestyle, don't do exercise anymore. No, 1% is clearly not enough just to put you in a safe zone. That's why I was saying before, you have to treat to lower risk zone, and then you need more, a bit more than just 1% for sure.
Okay. So I
But
think
a long journey start by the first step.
yeah. So I think we've answered Cheryl's question here about promote bone quality. We've, talking about our lifestyle and all that. How do you get a link to the seminar? I don't know what that is. Okay. When it comes to fracture prevention, is there evidence that greater bone quality results in fewer fractures? Yes.
Yes, I showed that to you before.
Yeah.
Yeah.
And I would like you to talk about, although I don't know if you had a slide about this, but when we have that fracture prediction, and if you go on the FRAX, and this is in my book, I have a whole chapter on FRAX, okay? That's the 10-year fracture model that we look at, which there's a lot of things wrong with that, but there's some good things about it. But when you add the TBS score into that FRAX assessment, let's say you have a -3, standard, you have a -3 T-score, okay? And now we're going to add in that TBS score, and the higher the better for TBS. Lower bone density, not the same, but higher the better for TBS. So let's say we have a 1.350, which is very, very good. Well, that -3 T-score becomes approximately what in terms of how we think about that now?
Okay, what will become approximately what? I can't tell you out of my mind.
Yeah. You'd have to do the math.
It's like I have to do the math, because it's like a complex formula just to do an equivalent of BMDT score. But maybe, so it will depend on the age and different aspects. But if you have -3 the T-score BMD and you have 1.35, depending on the age, maybe it will bring your patient to -2.5 or -2. So equivalent level of risk. Okay.
And then let's say, and this is what we're both trying to get across to everybody. So that's that gray area I talk about. Now, if that patient has had fractures that were very low trauma, they were walking across a lawn and they fell over and broke their hip, they're high risk for fracture. But if they've never fractured, then I personally, with that patient, and let's say they're 60, 65, I'd be leaning very heavily on nutrition and exercise and gastrointestinal health and improving all that. Would you tend to kind of agree with that yourself as a clinician?
Well, that will be a more researcher than a clinician, but as a basic, it doesn't hurt, and that will be really of help, because again, that's the basic things that have to be done for the health of the patients. That if you just pay attention to the nutrition and you pay attention to all the other factors you mentioned, and a good exercise, mostly impact loading exercise, enough protein, enough calcium and vitamin D through different nutrition and so on, and be careful about the gastrointestinal things and so on, then that would clearly help.
Yeah, and I might add that we don't have to wait, nor should a doctor wait 2 years to determine if their protocols with a patient is working. That's where the bone markers come in. And we don't have time to go over all the bone markers, but if you don't know what they are, in my book, or you can look them up, doctors should be ordering them. So in other words, if I put somebody on a particular protocol, or if they're taking medications in 3 months or 4 months, I can tell if they've been effective, or if their bone markers were kind of medium high a little bit. Now they're going to take estrogen. Now, those are the folks.
That's the beauty of the markers. The marker will tell you rapidly that something goes wrong or something goes according to plan.
Yes.
So whether or not the patient is reacting to treatment or the patient is not reacting to treatment. But then if the patient is not reacting to treatment, it could be either because he's a non-responder to these very specific drugs, or just simply because the patient is not very compliant. That's also happening. And we know that unfortunately, we have about 50% of the patient that dropping the drugs, taking their drugs after about 18 months or 2 years, where sometimes they should take the drug for 3, 4, 5 years to really get out the highest risk zone and just be in a better zone. And that have to be very cautious.
And
And
again, we know that by bone markers. So,
we know by biomarkers that the patient could just, oh, is in a good way. And biomarkers is clearly a nice tool just to check on the responsiveness of the patient and the compliance.
And also whether or not you should stop. So if they're taking a bisphosphonate and they're overly suppressed, that might be that period of time where they need to go off, right?
Could be.
Yeah. I'm going to be having on a doctor, I can't think of his name right now, but he's one of the top osteonecrosis doctors in the country. And you would know him, starts with an R, Rigidio. Anyway, but he really goes by bone markers. And if somebody's under 150 in terms of the CTX, he considers that a problem in terms of doing dental work. So
actually, yeah, well, clearly we have to be careful. You know, I mean, it's like biphosphonate or Prolia or all these drugs. They are, you know, they all are good drugs, but they have to be used properly. And it's not just like I'm giving my drugs and then I see you in 5 years. Or I give you the drug and you stop whenever you want. So it's the same with the Prolia, for example, of a potential rebalance effect or whatever. So all those drugs are good drugs and are very powerful to some extent at different degrees, but they're all powerful. And all strong drugs with the powerful drugs have to be taken care properly and administered properly, or stopped properly, or switch to another drug properly. Because if you don't do that, you may face some side consequences that is not related to, oh, it's a bad drug. It's just the fact that you didn't do it properly. Let me give you an example, a stupid example, but it's so true. If you're driving your car and then you decide that you're going to stop and buy a bread or something, you'd better stop the car before getting out of the car, otherwise you'd be in trouble. That's very much the same. You have first to stop the car, then to get off the car, and then you got to buy your bread. You don't jump out of the car while he's driving, okay? And that's the same with the drugs. So that means you don't stop a drug without talking to your doctor, or you have to manage the stop, or if you have to manage the continuation, or if you have to manage things properly. So everything is a matter of treating the patient well in a better manner and take everything into account to make the proper decision for the patient, even stopping potentially or be on a drug holiday for a while. But this should not be a self-decision, like without talking to someone that will really help you to.
No, they shouldn't be on self-decision, but here's what I'm hoping for: that patients get more educated so that they know that their doctors are telling them the right thing. And definitely you can't just, of all the drugs in terms of something that could really go badly if you stop quickly, Prolia is it. I mean, rebound fractures in the spine or no picnic, and that's rebound fractures. And I wonder, and of course we could probably do a whole new webinar on this one, but that's one of my concerns about Prolia. I mean, do you, I'm just curious, would you give somebody Prolia who's had vertebral fractures, non-traumatic vertebral fractures, or would that drug for you be held for somebody else? Just curious.
Well, first of all, it depends on the level of density and so on, because potentially with vertebral fracture, we may go for a PTH, like a Forteo or maybe Evenity, when it be approved, at least in Europe, is not yet approved. So depending where you are. But for denosumab,
Prolia.
Sorry,
okay.
for Prolia, yes. But again, we'll give that in the Center of Bone Disease when I'm working. My colleague was prescribed, they were the first to denounce the multiple fracture when you stop the Prolia. Okay, so the problem is not the multiple fracture or the rebound effect, so to speak. The problem is not to do anything or not to stop correctly the drugs. Now, if you stop that properly, then it will not be a problem. And we've been having different protocol now, the way we stop the prolia when it's needed, because potentially it's not needed. You can continue for several more years until you reach a lower risk zone. But then when you will decide to stop it, then you will potentially stop it, do biomarkers. When you have the right level of biomarkers, you will transition out with a biphosphonate just to minimize the rebound effect and definitely avoid the multiple fracture. And so far, using that protocol, even though we're still fine-tuning the way of doing it, what is the right period, what is the right biphosphonate, and so on the protocol we've been doing with some patients, we didn't have any multiple fracture by using that protocol. So again, it's not a matter, is a good drug, but assuming that we do using it properly. And if we do use it properly, then it will be okay. In what we know. Maybe more data will come down the road that will just say, oh, what you say, DJ, is completely bad. But as today, in the knowledge we have, it just has to be balanced by the way we're going to stop the program rather than stopping and say, oh, we don't want to hear about it. Because as a fracture reduction, it's a pretty good drug.
Okay, so let me, because we're getting to the end here, we may stay and do a few more questions, but I do want to say a couple more things on my own behalf here for a moment, which is that, and I'm going to show you again what you need to look at. But I do want to show my two books. This is my bone health book, and it's still valid. There's two whole chapters on bone density in this book. And my new book that just came out that has a lot to do with vitamin D. And by the way, my views about vitamin D and high dosing have very much changed, because it can actually increase serum calcium to levels that aren't good, as well as kidney potential problems as well. So that's my new book. All right, and let's see if there's anything else I wanted to mention here that you haven't. Oh, let me just ask you about this one right here. Strontium. Okay, now this is almost a swear word if I bring it up in conferences. And I'm wondering what your thoughts are about this, and if you have, first of all, is this still approved, or have they reapproved this in Europe, Protoleos?
Well, they've been, it's not been approved in all countries, and even in Europe, for example, in Switzerland, it's not approved where I'm from. The thing is, they had to stop anyway, even though you can have some generic of the strontium now in some countries. So it was not a bad drug again. The thing is, communication around the way it was functioning was not quite clear. And it's not really an anabolic drug, it's not really an anti-resorptive drug, it's something a bit in between. And the fact that the molecule itself has a bigger atomic number, just inflating the outcome in terms of BMD. And when we're saying a big BMD result, we say, wow, that's great. But
okay,
actually,
wait a minute, let me just say, because if people aren't getting that. So what we're saying is that the strontium falsely increases bone density. And it's much more so than we used to think. So in other words, you see your bone density getting higher, but it's really not higher because strontium replaces calcium due to where it is on the atomic chart, correct?
Exactly. And that's all. If you were correcting for that false inflation to some extent, then the increase was there, but not as important that it used to be.
Well, what about bone quality in terms of strontium? Do you have any?
In terms of bone quality, the strontium were having an impact on the TBS, on the structure of the bone. And the structure of the TBS was less impacted by the inflation of the BMD that it was, that the BMD itself, because the way it's calculated and the algorithm were less sensitive to the atomic number of the molecule.
So you think that strontium did have a positive, though small, impact on bone quality?
Yeah, it was having a positive impact on bone quality.
So do you think that the only reason, frankly, that they stopped using strontium ranolate in Europe is because of the bone density issue? I mean,
no. It's nothing to do with the bone density issue. No, it was mostly of a potential serious side effect. But even that side
cardiovascular, yeah,
exactly. It was very few cases. So whether or not it was, it's quite clear. You know, it's always the same problem when we don't always know the real truth behind the scene because there is so much politics or like smoke around the things. But it was not because it was inflated by the forced inflation of BMD because of molecule, because there were still true increase in BMD, but not as big as what we could appear. But that's mostly for the side effect that they have to shut it down.
Yeah, and well, the reason I bring this up, Dr. Hans, is because a lot of people in this country go to the health food store and purchase strontium citrate, which really even hasn't been studied. And a lot of people are using this. So that's why I wanted to get your opinion on it. And that's self-medicating because it really is a medication, even if you're getting it at a health food store, if you're taking it at high levels.
Well, you know, I mean, I would say, like I was saying to my kids when they were younger, they're not that young anymore. But if they were just taking products, you know, from a chemistry game and then mixing up without paying attention, you don't know what would be the outcome. It could be good or it could be boom in your face, you know, blow in your face. So I will be very cautious by taking something because most of the time, if there has side effect, we can potentially avoid side effect by having markers or just monitoring things carefully. If we do self-medication and something that could potentially be strong, then that's your own risk. So we just have to be careful on that. I'd rather you to have your self-medication in terms of calcium, vitamin D, and healthy lifestyles, lifestyle and exercise and so on, everything you were advocating, and that I will be 200% behind you, rather than just having self-medication, something that we're not quite sure about what will be the side effects.
Okay, well, we probably should go now, but I hope my questions have been okay because I've been kind of firing them at you, and I just love it when I can have someone here that I can ask these kinds of questions from.
Well, you know, I don't have the truth. I'm just sharing my opinion. So some people may disagree, and I accept that. So it's just a dialogue, especially when we don't see all those people that have been linked here. It looks like we're just having a face-to-face exchange, personal opinion, and I'm perfectly fine, fine with that. And I've just been answering to you in a very candid manner, and you know, I'm fine with that. So
well, I really appreciate your time, and I would really love to have you back on because I have more questions, but we've been at it for an hour and 15 minutes. Oh, people are saying that the website does not work that we gave to them.
oh, the website.
Shelley, if you're there, the website, somebody else check it before I get off here because if that's true.
Maybe let's see if I can go myself.
It's not instantaneous.
A couple other people try it. Let's make sure.
So if you go inside yourself, does it work? Because maybe there is a mistake in a.
Yeah, just check it and see if it actually works, Shelley. You sent it to me, and that's the link I used. So just take that link that you sent to me and make sure that that's. Oh,
That's
someone
okay.
else said it. Oh, other people are saying it worked. Okay, so it must have just been a couple of people. So just re-enter it. So it does work, Shelley. No problem. And
Okay.
all right. Well, this has been great.
And again, don't hesitate to. I'm not very kind to leave my email address because I'm just leaving thousand. But if they have additional questions or things being recorded, so I'm be.
Well, they want to know if the notes would be available. I don't know how I'm going to deal with this once this is closed out because there's just so many people. I don't see how I can really do that, but we could try to have like the notes that you had, you know, the slideshow that you had made available to them. So we'll see what we can do. So thank you all, and thank you, Shelley, and thank you, Dr. Hans, for a wonderful.
My pleasure.
All right, take care.
So bye now. Thank you all for your attendance. Bye now.